Hello, and welcome to the Disera Clinical Education's Oncology podcast. I'm your host, Hannah Powell, and today's episode features Dr. Jesus Berdeja from Tennessee Oncology in Nashville, Tennessee, and Dr. Amrita Krishnan from City of Hope, Orange County in Irvine, California. They're going to be discussing the role of GPRC5D-Targeted bispecific antibodies in relapsed or refractory multiple myeloma, such as recent clinical trial data, patient selection, safety considerations, and where GPRC5D targeted bispecific antibodies best fit in current and future treatment strategies. This episode is part of a larger educational program titled GPRC5D Directed Bispecific Antibody Therapy in RRMM, Clinical Evidence and Practice Implications. For more information about the presenters, along with the link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
So in myeloma, we have all these great therapies, right? So, and a lot of the new immunotherapies sort of are BCMA directed, but there's another great target in myeloma called GPRC5D. So would you mind telling us a little bit about what GPRC5D is? And then we can start talking about some of the therapies that we have targeting that antigen.
Sure. Thanks, Jesus. So, GPRC5D is sort of an interesting target, right? Because we discovered that it's on myeloma cells. It is actually expressed in other tissues in the body. So, for example, on keratinized tissue, so your nails, expressed next to taste buds as well. So the question is, what does it really do? I'm not sure that we really understand its purpose, but we do know that it's highly expressed on myeloma cells, which is what we exploit when we look at GPRC-related targeting strategies. I guess the real question then becomes, I'm going to ask you, do we really need? I thought you fixed everything with your BCMA CAR T cells.
Unfortunately, the short answer is yes, we do. So although there's a lot of excitement about the possibility of some of these therapies maybe being curative for a subset of patients, the majority of patients still relapse even after a BCMA targeted therapy. So I do really believe that we need a lot more directed therapies. And I think GPRC5D lends itself well to that. Like you said, GPRC5D, we don't know exactly what it does or why the cell is needed, which is very different from BCMA, right? So BCMA is very important for the plasma cells. And so unfortunately, it's expressed on all plasma cells, both the malignant and the benign cells. Whereas GPRC5D, the nice thing about it is actually it's expressed much more avidly in malignant cells and not so much in the benign cells. And I think that's one of the attributes of this antigen is that it's much more targeted towards the malignant cells, and perhaps that may be the reason why we're seeing a little bit less of an infectious problem with these products that target GPRC5D. But maybe we can actually talk about what products we're talking about. What is FDA approved that targets GPRC5D currently?
Well, I guess in that sense, it's much easier. There's only one FDA-approved GPRC targeted therapy, and that's talquetamab. So I think that's easy if you have to go to your cupboard of therapies, right? And you've decided on a GPRC therapy, that's the only thing you can pick. I guess the question becomes this whole idea of therapeutic sequencing, right? Where do we put this before, after, alongside BCMA-directed therapies?
Yeah, no, that's a good point. But maybe we could start by actually, you know this data incredibly well, but somebody else may not know this data incredibly well. So how did talquetamab get approved? I believe it was the Monumental 1 study, right?
Right. So yeah, exactly. So Monumental 1 was, of course, advanced relapsed disease. And what we show in patients with a median of 4 prior lines of therapy, including prior BCMA-directed therapies. There was a cohort that was allowed to have prior T-cell redirecting therapy. So that could be either bispecifics or CAR T. They could still respond to a GPRC-directed therapy. So overall, the progression-free survival in Monumental 1 in patients with a median of 4 prior lines of therapy was around 11 months. And that prior BCMA-directed cohort, it was a little bit less. It was about 7.7 months, but it still suggested that you can use this after a BCMA-directed therapy. And of course, since that trial came out, we've learned a lot more about sequencing, and probably we can optimize its use after a BCMA-directed strategy.
So do you think it should be relegated to the post-BCMA space?
That's a great question. I think that's where we struggle, right? Because Monumental 3, which, was pretty exciting data that was presented at EHA, was just after one prior line of therapy. So it was fairly agnostic. And the PFS data from Monumental 3 was pretty good. And the MRD negative CR rate also extremely high. So, and that was a combination of tau and Dara or talc Dara palm. So I don't necessarily think it has to be relegated to post BCMA. I think it becomes this idea of patient selection. To your point about less infectious toxicity with talquetamab, for example, versus BCMA directed therapies.
Yeah, no, I mean, oh, go ahead.
I was going to say, where have you been using it?
I completely agree with you. I think I think it is just as potent therapy as the BCMA directed therapies. But like as you noted before, because of some of the off-tumor expression in the surface of the tongue and the highly keratinized tissues, it does have these toxicities that are basically expected. That can be a little bit more difficult as opposed to the BCMA directed therapies where, my patients say they don't even know they're on therapy, right? So it really comes down to a quality of life and sort of this discussion with the patient about these side effects and where they stand, with the caveat that I think it is true, and I think as we get more and more data, we do see that the GPRC5D directed therapies are not as plagued as much as the BCMA directed therapies with severe infections. And the problem I have with the bispecific antibodies is that at least right now, all the studies are being given until the bispecific antibodies are given till progression, which means that the infectious risk doesn't go away until the patient's off the therapy. And even 6 months later, we have to be careful about the patient still being high risk for infections with BCMA directed therapies. So, in a patient where we're very concerned about infection, I agree with you. I think that GPRC5D targeted therapies make more sense. But I have to say, if that's sort of well managed, for the most part, I'm using a BCMA first, and then the GPRC5D. But I think part of that is also just because it's almost easier, right? We only have one that we can use as opposed to several drugs that are directed against BCMA. So I think almost that by itself relegates it to later years. But I don't think that's the answer, right?
No, but I think we're all kind of aligned there, right? So that, obviously with CAR T being approved in the second line setting, now with Majestic 3, BCMA bispecific approved in the second line setting, talquetamab is still only approved after 4 lines of therapy. So, just by default, it's still right now in that post BCMA space. To me, I think you alluded to the differences in side effect profile. And I think that's where the biggest education really has been to patients as well as to community providers of not being afraid of it, sort of forewarned is forearmed, right? And I think if patients understand these things could happen, they're manageable and they improve with time, that they are less afraid and it sounds less onerous, right? So it's just the taste changes, can be managed with dose and schedule adjustments. The nail and skin toxicities, we used to send everyone to a dermatologist. We never do that now, right? We have a handout for patients in terms of using nail hardening agents and emollients for their skin, things like that. And I think all of that has helped to make it a much more manageable therapy for patients.
Yeah, I think, you and I were both in Monumental 1, right? So, when we first started using it, we weren't expecting these toxicities. And it was, what's going on? What's happening? And even we were kind of a little scared. What are we doing to our poor patients? But I have to say, once we realized that this was an off-tumor on-target effect, and also we started realizing that at least, when you look at some of the data, the patients that had these side effects also seemed to be the ones that responded. It was almost it's kind of like cytokine release syndrome with with CAR Ts, where we're like, we want a little bit, we just don't want too much. But I think you're right. I had patients who really benefited from talking to other patients who are on the drug, to kind of help them navigate that whole first cycle. Because I think that first cycle is the hardest, where the side effects are new. And it almost seems like they're almost a little stronger. And then, like you said, they kind of tend to get better with time. And I don't know if that's just because the patient gets used to it, or because sort of truly you're no longer redirecting to those low level expressions of those tissues. And maybe it is less. And we've learned also, right, that with increasing the interval of the drug, significantly helps those. So I think you're right. It's the expectation is making sure that everybody's educated about the expectation of these potential side effects, which which I think are unique.
But, I think in a way the community doctors, they did such a great job with checkpoint inhibitors, right? You and I don't give them because it's not myeloma, but, they have a fair amount of skin toxicity, other side effects. I actually think talquetamab is a much easier drug to give than a checkpoint inhibitor. I mean, the toxicities are pretty directed, as you said, relatively manageable with dose and schedule adjustments and supportive care.
Yeah, no, I agree. What's interesting is, and there are other GPRC5D directed therapies that are being tested, including an antibody drug conjugate. And I think the one that's the most advanced is a CAR-T, that is directed against GPRC5D. And I don't know if you're involved in that phase 1 study. Were you involved in the phase 1 study for an Arlacel?
Yeah, we were, yeah.
So I have to tell you, the very first patient I dosed, I was very scared because I was worried that knowing that these potential toxicities of the bispecific, and the bispecific's given, slowly, you step it up, and then you kind of do it every 2 weeks, and you can stop it if there's significant toxicity. With the CAR T, as is the CAR Ts go in and they expand. And my concern was that expansion, that patients were going to get this really severe cutaneous toxicity and tongue toxicity, and it was going to be terrible. And what's interesting is actually that has not panned out, which is really nice. And I think it's just a different kinetics, I think, of the two different therapies. But the good news is that at least from that standpoint, the other modalities targeting this antigen are moving forward, and appear to be safe. So I think it's good. But none of those are approved. So we'll have to wait for more long-term data as to how well they actually work.
But I think, the other thing I did want to bring it back to this sequencing idea, because in that original Monumental study, I think we didn't really understand that going from one bispecific directly to another bispecific is probably not optimal, just because of not just target, but also the immune environment. There's a lot of controversy. Do T cells get exhausted or not? But I think the data does
Damaged anyway.
So
They're affected.
yeah, I think that's a fair. Yeah, they're tired, right? So they're yeah. So
No, I think you're right. I mean, this whole sequencing thing is very intriguing. I think most of us in our mind think we go from if we change a target, that's better than going to the same target. And theoretically that is true, but I think you're right. I think it really depends on what the prior therapy was immediately before changing your target. Because I think, and again, we don't know this, but I think we'll know this with some time as we're moving this earlier in line. Is it going to be the same for a patient who gets second line BCMA directed CAR T and now gets, talquetamab third line 4 years later? Is that going to be the same in terms of the effects on talquetamab as someone just finished a BCMA directed bispecific and is progressing and put him on talquetamab? We know that that's not a great scenario, right? Going from bispecific to bispecific. it's not completely clear, right? But I think, I mean, do you agree that changing antigen is probably the best? If you have that option, is probably the best way to proceed after you received one or the other?
Yeah, and I think that's what most of us do. I do think the best case scenario is relapse after BCMA CAR T, then going to talquetamab. Even there, the data that we have is retrospective data. There's some data suggest 6 months after your CAR, but to me, that's more a function of your disease biology and less a function of the time interval.
Yeah, that's true. I guess a patient whose myeloma responds and stays in response longer is always going to do better, right, than a patient that's progressing quickly. So it's always challenging to know, are those therapy specific or myeloma specific issues? But yeah, no, you're right.
And then maybe we should talk about combinations, right? Because I think most of us, yes, these were all approved as single agent, but do you want to speak to Monumental 3, right? Because that's kind of the first combo phase 3.
You're right. I think just like everything in myeloma, we think everything works better in combination. And there are some rational combinations with these T-cell redirecting therapies, with other therapies like anti-CD38 antibodies or even like the IMiDs or cell mods that tend to potentiate the T cells and cause immune modulation that may really work very well in conjunction with these T-cell redirecting therapies. And to that effect, we saw that it started with the BCMA bispecifics and Majestic 3 with the combination of daratumumab and talquetamab being incredibly effective and superior to standard of care. And now we're seeing the same thing with Monumental 3, which you just alluded to. These are patients who had had one or more prior line of therapy and were randomized to receive talquetamab with daratumumab plus minus pomalidomide versus standard of care. And the curves for both the talquetamab arms are well superior to the standard of care. Again, reinforcing the idea that the combination makes the drugs more potent. But in that scenario, I also wonder, is it the combination or is it moving it earlier in the line of therapy? Because we also saw with Majestic 9, right, with a single agent, teclistamab, also outperformed the standard of care in 1 to 3 prior lines. And so I think, I think the verdict's still out, but I think, especially talquetamab, I think it lends itself very well to combinations to potentially make this a much more powerful treatment for our patients. So what's your take on the combination studies so far?
Yeah, I mean, I think Monumental 3 data, you're right, the 24-month PFS, 81% in the Taldara Palm, 77% in the Taldara arm. And I agree. I think it's just using a bispecific in the second line setting is where you see the biggest benefit. So I think of anything, and then it becomes more nuanced of which one do you choose. I'm going to put you on the spot and ask you. Here, the question is, right? How much do you need to do Taldara Palm versus just Taldara, right? Because you only get because the trial didn't compare those two arms.
Yes, you're right. And I think, I guess the short answer is I think you can do either. But I think the question is there really a significant increase in efficacy by adding pomalidomide on top of daratumumab? And that's what we don't know. I think numerically it seemed like it was superior, but the problem was also there were more toxicity, more hematotoxicity, more infections. And so you kind of have to weigh whether the added toxicity is sufficient for that perhaps increase in efficacy, given that the two drugs are superior. So I probably would not do the 3 drugs in most patients. I may consider it in a patient that just has bulky disease where I'm trying to really kind of get them control, where I know that the pomalidomide combination it will work as an anti-myeloma therapy as well, not just as a potentiator for the T-cell redirecting. I might consider it then, but I think in most patients, I would probably go with a doublet instead of then I'll put you on the spot next, since you put me on the spot. That one is, all these phase 3 trials we're talking about dose the bispecific antibody until progression. So in your mind, are you going to be dosing these talquetamab, for example, after monumental 3, once assuming it gets an FDA indication, are you going to be dosing until progression, or are you thinking limited there?
Oh, that's a good question. I think in the first relapse setting, you'll be much more willing to limit duration of therapy. And if you have sustained MRD negative CRs, I don't know what that duration of therapy will be. My guess is somewhere between 2 years to 3 years, and then one would envision stopping.
And
Because I
I,
think
I,
many of
I,
us are already doing this with Monumental 1. We've extended duration. We've been too chicken to stop because that's a patient who's had 4 or 5 relapses, right?
Yeah, no, I think that's an excellent point. I think, I think we talk about whether we all talk about limited duration, but I think we really have to be thinking about the patient, right? If it's a patient that really is relapse refractory, is gone through everything we have, and they have a response to this, and it's tolerable, I would be cautious about stopping therapy in that patient. But like you said, in a patient that if and when they were to relapse after something like monumental 3 based therapy, you have options after that. I think that's where quality of life and the idea of how much do we need is important. And I agree with you. 2 to 3 years sounds like a lot to me. I suspect that as we move forward, that we'll find that after a year, if you're not in MRD negative, that maybe do you really need to continue the therapy? And I think patients achieve the responses so quickly. It's not clear to me how long they need it, but I think definitely from a quality of life standpoint, I think this especially something like actually both, but talquetamab, just given some of those side effects that patients don't like. I think if they know it's limited duration, it's going to get them to a deep remission, and then they get a treatment-free period. I think that is going to be the best way forward. But obviously, we still have to study that and do it cautiously.
And then the other point, allegedly higher incidence of GPRC resistance than you see with BCMA because GPRC has multiple mechanisms of resistance. So I do think also fixed duration of therapy may help also reduce the emergence of resistance.
Yeah, no, I think that's an excellent point. It's something we really talk about when we're doing sequencing. But with BCMA, after CAR T, it's unheard of, right? That you lose BCMA, although it can't. There are case reports. The majority of patients retain BCMA, and presumably later on you can sequence. With bispecifics, that's a little bit of a higher incidence in terms of loss of BCMA, but it's most of the time is mutations, right? As long as you have something that binds, perhaps you can overcome the mutation. But with GPRC5D, the early data is looking like patients who relapse after GPRC5D therapy. The majority of patients will lose GPRC5D. So is this a one and done type of therapy, or are going to be able to sequence? We actually don't know. But I like your thinking that if you stop it early, maybe you'll prevent that from happening for these patients. Is there anything else? Any final thoughts on this? We discussed most of these issues, I believe.
I know you work with a lot of community sites as well. What do you tell them just as a practical to start? And it's not just GPRC bispecifics, but just bispecifics in general.
I think talquetamab is no different than the BCMA bispecifics from a standpoint of the need for step up dosing before you get to the final dose, and most of the cytokine release syndrome and potential ICANS happening during that step up in first dose, which is where the REMS is required. And I think for the most part right now, most small community practices are not doing the step up. And as you know, when often they'll send them to a tertiary center like yours to do the step up to the first dose, and then you send them back. Hopefully they're ready to then continue dosing because the continued dosing is actually pretty easy. So the same here with in our practice. We have a very large practice, and we have I think about 35 different clinics, but some are actually quite rural, and some of them are they may have 1 or 2 doctors, and some don't even have a doctor. They kind of do a lot of remote because their goal is to try and get the therapies to the patients. So we still do the step-up dosing of all the bispecific antibodies, including talquetamab, in 3 of our locations that sort of are set up to do so. But then with the goal that then the patient then goes back to their home clinic, and all those docs are REM certified. The staff is as well to continue dosing. So I think it's just that communication and so, and then looking at studies, are we going to be able to do what we're doing with BCMA, where maybe prophylaxis tocilizumab will reduce the risk of this cytokine release syndrome to such levels that maybe this can all be done as an outpatient, and be done in local clinics? I think it's possible. I think it's a little bit further behind than BCMA, but I'm curious, are you giving it all as outpatient, or are you still admitting patients for observation?
We're doing it all as outpatient except for patients who have significant comorbidities or a very high tumor burden. But I've just recently had two 80-something-year-olds doing it as an outpatient.
And are you giving prophylactic tocilizumab?
Yes, we're giving prophylactic toci to everyone.
Okay. So you kind of do the same thing for talquetamab as you would with the BCMA bispecifics.
Yes, correct.
Well, I mean, I think that's all the time we have, right? So, I mean, Dr. Krishna, it's always a pleasure doing these with you, and thank you for your insights.
Thank you, Dr. Berdeja. I always enjoy chatting with you. We certainly have somewhat aligned views, but then we have some interesting differences in certain points. So I think we learn from each other. So thank you.
Thank you, Drs. Berdeja and Krishnan, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, GPRC5D-Directed Bispecific Antibody Therapy and RRMM, Clinical Evidence and Practice Implications, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.